Just a little background. When I started in oncology, I started my fellowship in '76. I think that this would have been a very appropriate topic to be talking about because at that point in time, oncology really was not in the same area where it is right now. I was the first one in my family to go to college. But when I picked oncology, I could see that they were very uncomfortable with that because of what everybody thinks oncology is or what it was then. But I actually do read an obituary every week. I subscribe to The Economist, and if any of you have read this, you know that the last page of this always has an obituary in it, and it's a celebration of somebody's life that they have. Here's an example of a number of the last pages that I have taken out and just put on my wife's sewing table so that I could take a picture and you get an idea of who's there. It's interesting because the obituaries are all written by one person, this person here, Anne Rowe. She's a English woman, she's an author, and she is the Economist's obituarist. She's actually, there's actually a thing on called the art of the obituary. What she does is very interesting. Her guiding principles that she lives by are, she picks people with an interesting story. And, you know, she has to write these up every week that she has. It's interesting, the time when Teddy Kennedy died, she didn't write an obituary about Kennedy. She wrote about a Filipino man who had circumnavigated the world on a raft just using simple instruments that he had. She talks about the principles that they lived by, discussed broadly their mission that they had in life, records their accomplishments that they had. She never discusses the cause of their death unless they died through assassination for the principles that they were standing for. And she doesn't discuss who they were survived by unless it was important for the whole story that she was telling. So I have a number of obituaries I'm going to run through, and they carry certain themes to them, and we'll talk about it. I figure we might as well get somebody to start with that everybody recognizes. So this is Sean Connery, or James Bond, as everybody knows. I'm sure if I ask you what your opinion is of Sean Connery, it'd be different from what he really was. He grew up in a slum in Edinburgh. He probably had no education or very minimal education. He was going to be a soccer player for his life until somebody told him he'd get a longer run if he went into acting. He is not the type of Bond that's described in the novels that he has. He was not kind to women. His first wife that he was married to, divorced him because of both physical and mental cruelty that he had. The second marriage evidently went well. He was retired at that point in time. Spent a lot of time reading and trying to catch up on things that he didn't have in his life before. And he may have been in His Majesty's Secret Service, but he was a staunch Scotsman who had the principles of Scots freedom behind him. Here's Donald Henderson, that many of you may know. He actually was at Hopkins when I was there. He was head of their public health department. He is a person who defeated smallpox. They actually picked him thinking that he would fail. The people of the World Health Organization never thought he was going to be successful in what he did. But he was what you would call a shoe leather epidemiologist, and not what they referred to as a shiny pants epidemiologist, meaning he was out in the field all the time doing work, figuring out how he was going to count who had smallpox, how he was going to get trucks over bamboo bridges and the like into everything. But he actually defeated smallpox. It was an amazing thing that he accomplished and made a great difference in our population. Here's a fellow, Yuan Longping, that I doubt that any of you have heard of him, but he was actually born in Beijing. His mother wanted him to be a lawyer. He was very interested in agronomy. He started crossbreeding rice when people thought that no one could do that. Virtually his work has fed an additional 60 million people that he had. He took the production in China from 50 million tons in 1950 to like 300 million tons in 2017. So a fellow who had a desire, spent his time in the field and worked, made a major advancement in public health that we were looking at. Here's Hank Aaron, and I know that Mike Jones either wrote something about Hank or talked about him at one time, but we remember him breaking Babe Ruth's record. It was interesting, leading up to that, he had death threats, he had hate mail, he was really bothered by the fact that he was being threatened all the time, that they did not want a black man to break Babe Ruth's record. And he played almost his whole life, excuse me, with the Atlanta Braves that he was with. After that, he became very involved in actually bringing young players into the league, helping them with issues of race that they had at that point. You have to remember, he came in the league in 1951, which was 4 years after Jackie Robinson actually broke the color barrier. We had a number of talks about racism this morning, and you'll see in a number of these people that I've picked, you'll see that they were involved in that way. So I went to St. Joe's Prep and St. Joe's College, which is a Jesuit organization, and I don't know whether you know anything about the Jesuits, but the Jesuits are really oriented towards education and also towards mission work. Philip Berrigan was a little bit later. He was actually when I was in med school where he was in trouble. He really felt that our obligation was to people that were underserved. And he physically, during the Vietnam War, he actually was in jail because he and his brother and a number of people with napalm that they made up burned a number of draft records so they would take the people out of the government's listing of them so they would not have to go to the war. It's interesting, he was chastised by Carlos Spellman in New York and also by J. Edgar Hoover. He was also the only priest that's ever been on the FBI's most wanted list during his life. But he made a major difference in our thought about the war that he had. Here's Norma McCovey. She's the Jane Roe of Roe versus Wade. I think Norma was really a pawn in this game that we had with this. She was not a very desirable individual. She had lots of problems with drugs, prostitution. She had multiple jobs that she was holding down. She had, the reason that she went to the lawyers who used her, Weatherford and Coffey, was because she needed to get rid of her third pregnancy. Her first pregnancy, her mother took from her, called her a whore that should never have to raise a child. And the third child, she was 22 years old and had no way of supporting it, and that's how she went into this. It's interesting, I didn't realize that when the court decided the Roe versus Wade case, that third child that she needed to get rid of was actually 2.5 years old. So she didn't really accomplish what she wanted to with that, but it changed the way we looked at things in society. Later, she had tremendous guilt with what she did and actually went to the other side. But she was not a desirable person that, that society wanted to hold up for their argument that they had there. They also will occasionally do things about companies that have stopped or different institutions that have ended. This company, this Bell company in London, was formed in 1570. Made the Liberty Bell, it made Big Ben, and it stopped this year. So this was something that was a monumental thing in the industry of bell making and the like that they had. Here's a teacher, Samuel Paté. He was a high school teacher who really wanted to make his kids think. He used art as a way of teaching this and had them discuss things in class with this. He's the fellow that talked about liberty in France and brought up the cartoon of Muhammad that was looked upon by the Muslim people as being really not very nice towards Muhammad. It got out that he did this. One of the parents went on Instagram, put his name on Instagram. A couple of people accused him of things that he didn't do. That weren't even in his class, and he was beheaded for what he did. A man who had principles, but died for it, what he had. In the same vein, this is a young woman who left Africa, Ethiopia, because of oppression over there in the war. She went to Italy. She actually started a goat farm. She gave the people there milk, cheese, gave them jobs, brought them in. She was murdered by one of her employees over a minor wage dispute that they had. Here she was trying to change something for the area that she was in. She was also persecuted because she looked different than the people in northern Italy where she was from. Madeleine Albright, this is the newest one. This is just from about a week ago or so. But reading about her, she was very interesting. I knew a little bit about her, but not much. It's interesting, she was Jewish, but she didn't know it. She was baptized Catholic because her parents were trying to protect her from the Nazis in the Second World War. When she was our ambassador to the United Nations, she was visiting Prague and was visiting the Pincus Synagogue and found out that her family was on the walls there, that she was actually Jewish. That's when she found out that she was Jewish. She was the first woman Secretary of State that we had. It's interesting, when she was, I guess not inaugurated, but appointed to that position, she showed up in a red dress with white pearls and a pin. You'll see she has a pin here. She was famous for her pins. When the Iraqis accused her of being a serpent, she went out and got a gigantic pin of a snake that every time she dealt with him, she wore that pin. When she wanted to have the press not talk about negotiations that were going, she wore a big mushroom pin, which said that some things grow better in the dark than they do in the light. And she used this. She thought that men were not great in this position because she said men are interested in power and position. Women are usually interested in negotiation and making peace. But she was a tough lady. She actually called she made a point that she called one of Castro's ambassadors as having no cojones. And she said that meant much more coming from a woman than it did from a man who told that. It's interesting, she married into a very wealthy family, the Albright publishing family. Her husband divorced her later on. She taught at Georgetown, and she always taught her women students that they needed to speak out, remember what their place is, and strive for where they needed to be. Very strong. Toni Morrison, she worked for Random House, but she wrote a number of books. She was the voice, I think, of Black America in the U.S. She wrote some really tough stories, won the Pulitzer Prize with it. And you're in Texas, so we have to talk about Larry McMurtry, who just died. Larry he was truly a cowboy in a way. He lived on a ranch. His address was the same for his whole life, 522 Archer, Texas is where he lived. Had a used bookstore, but he wrote on an old typewriter that he had all the time. His bookstore was touted to be the best bookstore between New York and Berkeley that they had. He believed in spending a lot of time talking to women because he said he learned a lot about sensitivity and what should be, how we should deal with people. He was credited with really correcting the cowboy image. He didn't like his horse. He was afraid of birds and trees that he had. And he he was not the Marlboro Man type of thing. He wrote stories about how cowboy and how Western life really was, but he also died recently. You have to remember, this is a international magazine that goes out. This woman, Catherine Hamlin, was a gynecologist who lived, I can't remember now whether she was in Australia or New Zealand, but she answered an ad to go to, I believe it was Ethiopia, to teach midwifery to the population there. When she got over there, she realized that one of the customs was childhood marriage, and found out that these women, their genitals were completely destroyed by having to bear children at a very young age and other things that they did. She really built a hospital for them. She ended up spending the rest of her life there. She and her husband there. They were going to go over just for a few months to take this job, but this became her whole life that she had, and she died recently as well. This is a physician that Marvin knows as well. This is a Robert McClellan. He was a surgeon at Southwestern in Dallas. He was an excellent hepatobiliary surgeon. He was a kind man. He would go to any of the cities, whether you were affiliated with University of Texas Southwestern, or whether you were Presbyterian or Baylor. He used to come over to our place all the time to help with difficult surgeries. His claim to fame, though, or his fame, is centered around this shirt that he has on his lap. He saw in the museum in Washington the shirt that Lincoln wore when he was assassinated. He happened to be on staff at UT Southwestern for 1 year when Kennedy was shot. He had to go to the emergency room and take care of Kennedy. That shirt has the blood of Kennedy on it that he saved through all these years. You know, there's a big battle here in Texas because Texas has a law, if somebody if there's a homicide in Texas, that they have to have a post-mortem done in the state. However, the federal people took Kennedy's body, would not let the autopsy be done here, and took him back to DC. He really didn't talk. I mean, he would talk if you wanted to talk to him about this, but he did not. He saw the autopsy report, and it was clear to him that there were two separate wounds coming from different positions on Kennedy. There was an exit wound posteriorly and an exit wound anteriorly in the throat. Didn't say anything, didn't raise anything, but he thought that a lot had been whitewashed with what was gone there. But this is what they remember him for, is Kennedy, and then 3 days later, he had to do the same thing with Lee Harvey Oswald, who was shot. Unfortunately, Oswald went and flinched when he was shot, which caused the bullet to go through a number of organs, and he died as well. But that's what they remember him for. He was a kind gentleman and a very, very good surgeon. Now, I'm going to ask Bruce Fye to come up because Bruce knows James Tate Goodrich well, and many of you in the audience may. I didn't really know him, but he was an Oslerian. And you have to remember this, he had an obituary in this international magazine. So Bruce, why don't you come up? And Bruce sent me this picture, which he got.
Thanks very much, Bob. I met Jim Goodrich in 1984 when he won the Osler Medal of the American Association for the History of Medicine. And when I first met him, I thought, this can't be true. This guy's a clinician, a bibliomaniac, he likes Osler, he's a bookseller. I mean, this can't be possible. But the reason that he really became very well known was his neurosurgical career, especially when he separated the conjoined twins that were joined at the brain. And I'll digress momentarily and say my first clinical rotation as a medical student at Johns Hopkins was in neurosurgery. And that's probably not the place you really want to start as a third-year medical student. And Larry Gelsma was the senior resident, and I was in charge of the sucker thing. And I'll never forget, he said, "Don't suck that, that's brain." So I was really, I was convinced at that point my future was not in surgery. So I was very, very impressed, obviously, watching Jim's career unfold. But he was an ardent Oslerian. In fact, I bid against him for many Osler items. Many of you would remember Chuck Rowland, an extraordinary guy. Jim outbid me with Chuck for the first part of Chuck's Osler collection. I outbid Jim for the second part. But he was a remarkable individual. I think probably many of you don't really know him because he wasn't as active in recent years before his death because he was so involved in his clinical life. But he was a remarkable individual. In fact, the last time I saw him was at the auction of my own books in New York City in 2019. That's the very last time I saw him. And he was sleep deprived coming back from Europe, and he was complaining he hadn't gotten the catalog till that day. I said, that's too bad, but welcome back. But he died about 2 years ago on March 30th, and 2 years ago, at the beginning of the COVID pandemic, and was one of the first physicians I'm aware of, and certainly my closest friend ever to die of it, very, very early on. So I can't go into this story because this is Bob's evening, but a remarkable individual who had multiple lives simultaneously, and I think I appreciate the opportunity to say more than a few words, but a few words about Jim Goodrich. Thank you.
So this has shown that my habit of religiously reading obituaries, the Economist Weekly obituary, is not a morbid or ghoulish event. It's something that's, my habit is quite wholesome and celebratory of life. It sort of gives me people that I should be emulating and trying to force some of their principles in things that I should be leading my life. So I look at this and I see what people have accomplished, and I know that I can still do a lot more, but I know there's other things to do as well. So who should I follow? Obviously, this is the Osler Club. Should I follow William Osler, who's, he actually practiced and he died while he was still active, probably not as active as what he was 20 or 30 years before this? Or should I follow Rocky Marciano? Rocky Marciano was the Brooklyn blockbuster. He won 49 fights, 46 by knockout, 3 by decisions, and lost none of them, and retired after the last one at his height, at his peak. I'm not at my peak anymore, so I can't do that. But I look at this, and it poses problems for me. It poses problems for all of us. So when should you retire? So here's Harvey Cushing's quote. Why not put a surgical age for retirement for the attending surgeon at 60, and for the physicians, or the internists in other words, at 63 or 65 as you think best? I have an idea that the surgeon's fingers are apt to get a little stiff, and this makes him less competent before the internist's cerebral vessels do so. So here's Harvey Cushing saying I should have retired a long while ago. But then I look at Joan Fenman. Her brother is Richard Fenman, who won the Nobel Prize. She was also an astrophysicist. She died, I believe, when she was 90, but at 88, someone asked her why she is still researching, and she said, I still have a lot of questions I want to answer. Do you want to do it? It was very interesting because this also shows some discrimination that went towards women at this time. When she went ahead and was doing her PhD thesis, one of her advisors or faculty members, her thesis was on radiation absorption by crystals. And one of her thesis, not advisors, but one of the other faculty members said, maybe you should specialize in cobwebs because it's better for cleaning the house and things like that. She applied for a research position in the New York Times, and they wouldn't let her apply in the men's section because you said you can't do it, women don't do it. Her mother said women's brains are too feeble to do science. But she made major advances in the study of the corona, the sun, you know, the northern lights and everything that she had. She and her brother, when they were younger, she took that, he took all the rest of astrophysics. Like I say, he won a Nobel Prize, what he had. So whenever we're making any decision, we need to weigh the pros and the cons of what we're looking at. That's how we operate all the time, okay? So this is, I'm going to show you a story here. I accidentally sent this, but this is a 55-year-old woman that was sent to me by an endocrinologist, Dr. Nealon. This is something that I really had not seen before, but the endocrinologists and renal people did. This woman was breaking bones. She had to come in a wheelchair. She couldn't walk because she had fractures all over the place that she had. She had a low phosphorus in her blood. She had a high phosphorus in her urine. She had osteomalacia. So the reason that the endocrinologist sent her to me, a young woman endocrinologist, she knew what she had. There's a very rare entity that's called a hypophosphatemic hyperphosphoruric osteomalacia of mesenchymal tumors. Extremely rare. Most of the oncologists don't know about this. The renal people know about it. The endocrine people know about it. She sent it to me because we had a test at that point that was only available at the time when she came for about 3 years. It was called a dotatate scan, a gallium-67 dotatate scan. We used it in neuroendocrine tumors. But this particular tumor, which is usually extremely small, and usually the person can be cured if you remove it, and it makes a substance which causes them to break all their bones and the like, also shares the same antigens that you can look for with this tumor. And if you look at this, all this is normal. This is their liver, spleen, GI tract, kidneys that you have, bladder. But right there is one spot that shouldn't be there. And if you look at it a little further, this is all the screens. We're just going to look on this side. Here's the same screen. Here's another way of looking at it with the PET scan. You can see it's really hot there. And this is the CT scan that goes along with it, which I'll show you in the next one, which is the same picture. You can see that in this space right here, there's something that isn't over here. So we had Al Malabashi, who's one of the orthopedic oncologists, go in and just, this is a slam dunk operation, take this thing out that was 2 centimeters, or it was about 1.5 centimeters. She now lives in Mexico with her husband half-time and her grandchildren. She comes back here all the time. She's not in a wheelchair. She walks. I didn't do anything except I was the only one who could order these tests. An oncologist could order because they're pretty expensive tests, but it showed us something that we never would have been able to find, 10 years ago, and have just changed this woman's life. So the science of medicine is changing this field. Oncology is changing every field, but oncology really dramatically. So here's a 72-year-old man who 2 years ago had a pleomorphic sarcoma. These are very aggressive sarcomas of the right thigh. He comes in Monday, his creatinine is 7.5 that he has. So he's in renal failure. He had to go on dialysis specifically for that because of a drug that I had given him, but also because he wasn't paying attention to what we asked him to do. But here he is in October of 2018, and you can see here, this is all tumor. Over here on the right-hand side, that's all tumor that's encompassing his right lung. On the left lung, which is right here, you can see it's clear on that, so he shouldn't have that. If you look at the film that's on this side over here, you can see that basically all that is cleared. Here's another view of it. Here's doing the coronal view like this. You can see that this area that's all over there on that right side of the lung is tumor. That's clear. If you look at the date, that's October 2018. This is June 2021, which now he is still clear. I didn't do the one that we had in December, but he's out over 3.5 years with no evidence of his disease. He should have been dead, but he's not, and it's because of the things that are changing so dramatically in the field right now. Here's the 2 people that won the Nobel Prize in 2018 for immunotherapy. Jim Allison is a PhD doctorate who's at Anderson, and he found CTLA-4, which is a brake for the immune system. And here's Dr. Hongo, who's in Kyoto, who found PD-L1. Both of them found the drugs for this. So you have to realize that everybody in this room has cancer. You don't have the disease cancer, but you have cancer cells. There's something about a cancer that oftentimes will shut the immune system off from recognizing it. These two guys found what it was. They found a brake for the immune system. They also found the drug that acts as a cover to the brake for the immune system, so it turns the immune system back on. This gentleman was treated, that I showed you his picture, was treated with an injection of a monoclonal antibody that Dr. Hongo found. You've probably seen it advertised as Keytruda, or pembrolizumab is the other name of it, and he's still going strong. Another example of this is with the immunotherapy for melanoma. Now, the person I'm going to show you an example of this is Steve Rosenberg, who is a surgeon. You have to ask, what is a surgeon doing immunotherapy research and finding out? And that's another story, which if we have time, I'll tell you later, but not now. So what he did is he knew that these T cells, which are what is turned on when you go ahead and allow the immune system to act, that if he could find the T cells that attack the tumors and give it back to people, that you would probably see a response. So what he did is he would take the tumor out, which is on the top part of this drawing. I'm sorry, I don't have a pointer here for this. He would go ahead and incubate them, find out the cells that are really active, sort of separate those out, which are the red ones over here, grow those up and give them back to the person. Here's a person who has a melanoma on the right. He had chemotherapy, and like it did not work. He had surgery initially. This had grown back. All he had between this picture and the picture that is on your right is he got his own T cells given back to him after he had grown them up in a number that would allow him to give him a lot of these lymphocytes back. That thing went away completely. He had no radiation, no surgery, no chemotherapy that he's had. Here's Steve Rosenberg, who was head of the surgery department at the NCI. And next to him is Carl June, who I'm going to tell you a story about him. So here's Emily Whitehead, very nice 16-year-old girl. She should have been in my obituary pictures that we had. She had a form of acute lymphocytic leukemia that was refractory to everything that they had been giving her. And her father and mother were pushing to do anything that they could, obviously, to save her. She was probably 11 years old when this happened. She was the first person to get treated with CAR T cells. These are engineered T cells where they engineer them against certain antigens on the tumor and then give them back. She got that treatment, okay? She went and got the treatment from June. She was the first patient that got treated like that. However, she got a tremendous cytokine reaction, which we'll oftentimes see. Had blood pressures that were down in the 60s. She was on a respirator because of pulmonary inflammation that she had from this. She was encephalopathic because of the cytokine therapies, the cytokines that were being released by this tumor, which was being attacked by the T cells. Her pediatrician at Children's Hospital of Philadelphia was Stefan Group. He actually went ahead and just measured what the cytokines were, and he found out that she had really an excess of something called cytokine 6. There was a new drug, a new monoclonal antibody that had come out that blocked cytokine 6. Gave it to her, she completely recovered. She was literally within about 6 or 8 hours of being dead of this thing, and she is completely recovered. She's a normal 16-year-old right now. So you can see what we see happening in our field, and it's not just in oncology, it's in everything, how it makes it hard to think about leaving this. So these are two people I know very well and work with. Joyce is actually one of my partners. Marvin knows Joyce very well, and he knows Dan Von Hoff. Dan was, he is a oncologist, a medical oncologist. He is actually one of the co-owners of Translational Genomics. He has been president of the American Association of Cancer Research, and he comes to our institution, was doing it every 6 weeks before COVID to act as a consultant, but is really a guy who's really a forward-thinking individual. Joyce really wants to cure breast cancer. That's, if you talk to her, that's what her goal is. And if anybody can do it, I think she probably can. She is, I'm going to show you an example of one thing that she was thinking about, but if you just look, she's the person that introduced something called PARP inhibitors as a treatment, and she was also the one that introduced the immunotherapy to triple-negative breast cancer that we had, one of the prime authors on it. So here's a case of a woman who has a large breast cancer, you can see circled there on the right, that had gotten all the normal chemotherapies that we had, and it didn't budge. She went ahead and did an analysis on that tumor and found out that that tumor had a BRAF amplification, the mutations that you see here, in a P10 underexpression. She knew that there had been work with both MEK inhibitors and AKT inhibitors. These are new drugs that are out there now that can block the mutations, the effect of those mutations that you have. So her tumor went from the one that you see on, again, your left to the one that you see on the right there. And if you look at the dates, it's 5 months. I'm sorry, it's 2 months that it took for it to do that. This woman is still alive with her tumor without any disease that she has at this point. Dan has this paper in the New England Journal, had a young fella who had a medulloblastoma, this tumor that you see encircled there in the brain, had this PET scan that shows all the nodal disease, all the bone disease that he had. He had been through all the chemotherapy. He was a young fella, had nothing, no response to it. He was also going to die relatively soon. They found out that he had a mutation in what's called the hedgehog gene. And there's 2 drugs that they have for that, and they treated him with this drug that just went by a number of them, but it's vismodegib is the drug. And this is one that acts inside the cell, and you can see that between April of 2008 and June of 2008, he went from that picture where everything was involved to where he had few things that were involved there. Unfortunately, he recurred again a number of months and has died of his disease, but it shows how, with people that want to try things, how we found things that we could go ahead and potentially look at. Science of medicine is changing the field dramatically again. This is a fellow who is presently a patient of mine. And I'm going to put this down here and tell you what this means on the bottom. He's a 35-year-old fellow. He and his wife have a 2-year-old son. He obviously has all the reason in the world to live. He's a sports writer. He writes for something called The Ringer. And you can go online and look up The Ringer and put in, "Does my son know you?" which is an article that he wrote. I can use his name. I'm not going to, because he writes about it. And you can find him on the internet. But he's a fellow who has an unusual variant that's just been described in a sarcoma, Ewing sarcoma, called the B-core CCNB3 fusion sarcoma. What we know about that is that they usually don't do as well as most Ewings do. If Ewing's has localized disease, we can cure them about 70% of the time. If they're not localized, they're going to die of their disease, and we don't have really good therapies. So we analyzed what he had. He had a P53 mutation, which is something we'll find in most people with cancer. P53 is a gene that we each have 2 copies of that is constantly removing the DNA damaged material that you have in your body. It's sort of the garbage collector for damaged DNA, and helps when the T cells destroy tumors and like, for you to get rid of that. So we did an analysis of his gene, and it's interesting. He also has mutations in these 4 genes over here, the APC gene, which is something seen in colon cancer, the FGFR4 gene, which was originally described as being found in gallbladder cancer, MAP kinase 1, and the NTRK gene, which we have drugs for. However, these are all variants of unknown significance, which means that these are changes in these genes that have not definitely been associated with certain diseases yet. They could be, okay? But the quandary that I have right now is I have this fellow who's 35 years old, who's gone through 3 different regimens. He goes down to Anderson and he sees me as well, who I don't really have anything else that's effective for him. I do have some drugs. I can't use them because they're still investigational, that if I knew if he had a genetic mutation in one of the areas that's truly a driver, that we could probably get a good response for him. Whether we could cure him or not is different. I mean, it is a difficult question. But, you know, it just leads you to think that if this was me, if I was a lot younger, and if I had something like this, I'd try like heck to get one of those drugs and not use the standard things that insurance is ready to pay me for, okay, or pay for, but isn't going to work, you know, isn't going to work and give them a lot of toxicity. So the last part is, when medicine is not fun, it is still usually very rewarding. This is the part that our patients are really wonderful. So this is a 37-year-old woman, 3 children, ages 4 through 10. The 10-year-old has an Asperger's variant and is really having a hard time with his mom being ill. She's found to have widely metastatic disease to bone, liver, and lungs. Biopsy shows a uterine stromal sarcoma that we don't do well with. Occasionally we'll get a good response. We've tried the standard therapies in 3 research trials that she's been on. And this is what her lung looks like. If those of you who are not used to looking at it, the big thing up the top is her heart. All the other are tumor nodules that are in her lung. She fortunately is not short of breath, but she's going to be there. This is a non-contrast CT, so these don't stand out very well. But you can see that that's a large tumor on the right side, also on the left side. She still wants to be trying things. We're looking for things. I don't have anything that I can really give her, that I can give her any kind of hope that I think it will really work. But you know, it's really interesting. Her husband has taken a leave from his work. They've really come together as a family. We've been able to get Child Life to help them, where the family's starting to gather. And now they're getting into the point that they know that their mom's not going to be there for a long while. They let me in on a lot of secrets of what's going on in the family and the like. And it's something that isn't easy to take, but it's something that's very rewarding when, you know, we in medicine get such tremendous trust from the people that we're taking care of. And it's extremely important. The other thing is, I think is great, is that we are constantly dealing with young people. So for all the students that are here, I can guarantee you that you teach your professors as much as they teach you. It's good to be around young people because you're not indoctrinated into the system to think about it in a certain way. You ask questions of us that make us think that maybe we're not doing things the right way, and maybe we should be looking at a completely different way as to how we do it, okay? So it's important. You got to keep up your desire to be inquisitive. Ask questions. Ask them politely, but ask questions, you know? And it keeps the whole field moving ahead. The other thing that I love about medicine is the camaraderie. Here we are. I'm pretty sure this was at Mayo. Those of you from Mayo, I think this is the Mayo Library, where you see Bill Roberts, who's over here, and Marvin, who's here, and Rob, who's there. and myself. You can see all the weight I've lost since that time. So, I mean, it's a wonderful field, you know, and the problem is when you're starting to think, are you going to retire? You know, I know that at some point I really need to do that. It's probably getting really pretty close to it right now. All my patients ask, now you're not going to retire, are you? And then my partners ask, you're not retired yet? You know, like this, and you have. So it's something that's offered me a lot of problems. So you don't retire, you really refire. You got to think of something else. I mean, you need to do things. So it's a chance to travel. You know, that's great. Of course, COVID has kept that off the radar here recently. Chance to do something that fires your imagination up, fires your desire up, something that you can't do if you're actively practicing. It gives you more time with your family. I guess it was Osler who said that medicine's a cruel mistress, and that's probably true. I mean, if all of us look back who've been practicing, we realize we've probably stolen a lot of time from our families while we're taking care of other people. It's a noble thing to do, but it's still hard, you know, when you have kids and family and you're trying to keep both going. So I've traveled. I mean, I love traveling. We went to Prague, we went to Paris, we went to Tokyo, we went to Florence. I went to those when I was going to the Connective Tissue Oncology Society meetings usually. So I don't really have to retire to do that. I mean, we can go and do it, other things. So the other thing is getting something that really fires you up, okay? Something that you couldn't do if you were actively practicing. So I have this 55-year-old engineer who has a carcinoid tumor with a carcinoid syndrome. When he was not on his medicine, he could be sitting on the exam table and you could just see him flush, turn red, then he'd go pale, and then he would turn red again. He loves talking to medical students, residents, and fellows because he wants to tell them all about carcinoid. And it's much better letting them go in there for an hour with him than having him read the chapter in the book, because he'll show them everything that's going on. So our first year fellow, Scott Buis, was in with him a couple of weeks ago, and I knew that medicines were expensive, but I didn't know exactly how much it cost. So he's going through, he's given Scott the whole story of what's going on with him, and saying that he's really debilitated if he doesn't get this monthly shot of octreotide. And he says, how much is my insurance company being charged for this shot that I take once a month? Scott says, I don't know. I figured I was going to guess. I figured where was I? Guess low. Anybody know what he gets charged for this? And this is not one of the more expensive drugs that we have. Pardon me? What did I hear?
8,000 a month.
8,000 bucks a month, right? Well, you missed it by not 22,000. You missed it by 17,000. It's $25,000 a month he gets charged. That's $300,000 a year. You know, I think that if I was going to do something outside of medicine, I mean, outside of real active practice of medicine, I would start looking at these things about the inequalities. I mean, this is really not sustainable. I mean, even if the insurance company's paying for it, that's money that's coming out of the healthcare dollar that maybe we could do a lot better with vaccinations or things like that we're looking at. And I'm not so sure how ethical that is. I mean, I know how some of these drugs are priced, and you have to really wonder whether it's a reasonable thing to be doing. The other thing is, I think we have wonderful healthcare if you have really good insurance and if you're wealthy, or if you're wealthy. But I think our healthcare really stinks if you don't have either one of those. Accessibility to the healthcare. You know, we were talking today about discrimination. There's certainly discrimination in healthcare that we see around this country. Question is, you know, we at the Osler Society think it's very important that we make sure that our students are talking to patients, not just relying on technology, spending time with people and listening to them. And I agree with that completely. But I think it's really important for us to really look at what all the outside forces are doing to medicine. Medicine, unfortunately, I think does take away from that in a way, but you know, we have to get our balances correct. We have a lot to learn from these obituaries that I showed you. We learned a lot about life. We're not really looking at death. We're looking about what people have done with their lives. And we have a great example in Osler, who gave us a wonderful way to live in medicine. I just wish that Michael Bliss had written a book that says, William Osler, A Life After Medicine, as to where we go with that, because it's something I'm dealing with. Any questions? None? Thank you very much.